Hello everyone, starting with general pathology revision, starting with cell injury and cellular adaptations and their changes. So the first thing is the most common cause of cell injury. We have many causes of cell injury, but most common being the hypoxia, and that is because of the ischemia means less or lack of blood supply is there. Okay, that is because of it might be the supply is less or the demand is more. Okay, the most important cells, I mean the cells which are mostly sensitive to the hypoxia is neurons. But if they ask you what are the cells which are resistant to hypoxic changes, they are fibroblasts, and fibroblasts are there followed by your skeletal muscles. Okay, they are most resistant to hypoxia. Coming to the cellular adaptations, the important are hypertrophy, hyperplasia, atrophy, and very important one is metaplasia. Starting with hypertrophy is something where the cell size is increasing. And why the cell size is increasing? The cell size are increasing because of increased synthesis of the cellular protein. So the cell size is increasing, cell is going to be mota. Okay, so what are the genes involved here? You can remember motor gatta, that is GATA, gatta 4. Okay, mota is something that is what is known as what is fat na, so you can remember it as N fat. So these are the genes also involved, like MEF2, that is also involved. These are the genes, these are the genes which actually increases the proteins, and increased synthesis of the cellular protein is leading to this increased size of the cells. And these are seen permanently, these are seen particularly in the permanent cells or non-dividing cells, means those who cannot respond to the insult by increasing their numbers can be hypertrophied. So they can be hypertrophied. Okay, like cardiac muscles, skeletal muscles, they cannot divide by themselves. So whenever there is insult, so they will increase in size. Like chronic hypertension can lead to left ventricular hypertrophy, that is a pathological example of hypertrophy. Okay, in bodybuilders you will see that the skeletal muscles are getting hypertrophied, that is an example of physiological hypertrophy. You will see physiological hypertrophy and hyperplasia both in uterus and breast, uterus in pregnancy and breast in pregnancy and lactation. You will see physiological hypertrophy as well as physiological hyperplasia. Okay, so please do remember that things. Also you can have the pathological one, like in case of bladder outlet obstruction by stones, you will be seeing the hypertrophy of the proximal segment. Hyperplasia means there is increased cell number, and that is because of increased growth factor induced proliferation. So growth factor induced proliferation is there. Okay, growth factor induced proliferation is there, so that is leading to increased number of cell of, and obviously that will be seen in case of dividing cells. Okay, what are the examples of pathological hyperplasia? Because of increased androgen, the response is BPH, benign prostatic hyperplasia, or because of increased in estrogen, that can lead to endometrial hyperplasia. Now this hyperplasia is a very much fertile soil for the cancers to develop. So like the endometrial hyperplasia can lead to endometrial carcinoma later on. So that is very, very important. Liver as a compensatory mechanism can regenerate, and that is what is hyperplasia of the liver. So this is the property where the liver transplantation is done. Atrophy means the cell size and numbers are getting decreased, so the organ size is also decreased, and that is happening as we ages. As we age, the senile atrophy happens, and the many organs are getting atrophied. Okay, pressure atrophy because of pressure. Okay, denervation atrophy because of lack of nerve supply for long time. Okay, the person will not use that limb particularly, there will be disuse atrophy, denervation atrophy, nutritional atrophy can be there, and ischemic atrophies are there. So this is because of decreased protein synthesis, increased protein degradation by ubiquitin proteasome pathway, and autophagy. Please remember, these are the physiological causes, pathological. The physiological ones, like thymus is present in thymus is present in the childhood, but it is getting atrophied when we this thymus and notochord is present in the during our development, but this is not present. So the regression that happens is by means of atrophy. Next, very important is the metaplasia. Metaplasia is very important. Metaplasia is a reversible change. First thing you have to know, it's a reversible change. That means if you withdraw the offending stimuli, then the change can be reverted back. And what is this change? So here what happening, the thing is, one differentiated cell type is actually converted to other differentiated cell type. So one differentiated cell type is converted to other differentiated cell type. So differentiated means these differentiated cells are actually produced from the stem cells. Okay, so if there should be some changes in the stem cells, that's why the ultimate product of the stem cell, that is differentiated cells, are getting changed. So obviously the pathology here, or the mechanism of metaplasia, is reprogramming of these stem cells, because the setting of this stem cells are getting changed. So now they are giving another kind of epithelium or another kind of mesenchymal tissues. So like we can give Barrett's esophagus as an example. Barrett's esophagus is columnar metaplasia. See, whenever I say something metaplasia, that means the changed to that metaplasia. Like columnar metaplasia means it is changed to columnar epithelium. If I say squamous metaplasia, that means the epithelium has changed to squamous epithelium. So normally Barrett's esophagus means you have the lower esophagus, that is stratified squamous epithelium. This stratified squamous epithelium that is there, that is converted to the intestinal type of epithelium, that is columnar ciliated epithelium, and this also will be having the goblet cells. So you can put the dye, that is Alcian blue or mucicarmine. These are the special stains that are used to diagnose the biopsy specimen of the Barrett's esophagus. Okay, the most common one is the pseudostratified columnar pseudostratified ciliated columnar epithelium to stratified squamous epithelium. And where that is happening, it is what is known as squamous metaplasia, that is mostly seen in smokers. Okay, in smokers, the pseudostratified ciliated columnar epithelium of the respiratory tract gets converted into stratified squamous epithelium, and that is reversible. If the person stops smoking within a particular time limit, then this change can be reverted back. Okay, please remember, it is associated with vitamin A deficiency. Metaplasia is associated with vitamin A deficiency, and another connective tissue metaplasia example is myositis ossificans, where the muscle is converted to ossification, that it is ossified to bones. Okay, you can see this image. This is where there is stratified squamous epithelium of the esophagus. Okay, and this portion is stomach. Now here you can see this portion is stomach. You can see the glands of the stomach, and here you can see this area where you see intestinal type of metaplasia had happened, and these are the goblet cells. Okay, so metaplasia types, you have epithelial metaplasia, mesenchymal metaplasia, as I told you, smoking, Barrett's esophagus, and mesenchymal, it's connective tissue metaplasia is there, and vitamin A deficiency metaplasia can happen. I told you this thing. So Barrett's esophagus, it's a columnar metaplasia because the stratified squamous is getting converted to columnar, so it's a columnar metaplasia. Okay, and what is the risk factor? It is repeated exposure to the acid reflux, that is gastroesophageal reflux disease. And what carcinoma increased in Barrett's esophagus? Please remember, it is the adenocarcinoma of the esophagus. The risk of getting adenocarcinoma is increased because of Barrett's esophagus. What are the histological hallmark? I already told you. It is the intestinal metaplasia and the presence of goblet cells. What is the special taint? Mucicarmine or Alcian blue, I told you. These are blue, 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 all the Alcian blue or mucicarmines. Okay, see, these are the glands, you can see. So these are columnar epithelium with goblet cells in between. You can see the goblet cells here. These are the goblet cells, white. Okay, and this is what is stratified squamous epitheliums. Next, coming to cell injury. Next, we have reversible cell injury and irreversible cell injury. Okay, this is a rapid revision. So reversible cell injury means here whatever changes are happening, if the offending stimulus is withdrawn within a particular time, ultimately the changes can be reverted back. So this, the most important thing that is happening here is the intact membrane is what is there. Intact membrane is happening there. So basically this reversible cell injury is because of the mitochondrial stress. The mitochondrial stress, please do remember this one, because when I'll be talking about irreversible cell injury, there I'll be telling you it's the mitochondrial dysfunction. But here in the reversible cell injury, because of hypoxia, there is mitochondrial stress, and because of mitochondrial stress, the sodium potassium ATPase is not working. It is not working. The sodium potassium ATPase का function क्या है? It brings two potassium inside the cell, and it actually there is three sodiums that are getting effluxed out of the cell. So this is the function of sodium potassium ATPase. If it is not functioning, so sodium cannot go outside, sodium retained within the cell, within the organelles. And if sodium is inside organelle, what is residing? The friend of sodium is water. So sodium and waters are there, and because of there will be hydropic changes. That is what is cell swelling, and that cell swelling is leading to membrane bleb formation. Understanding why there is membrane bleb formation? These are the blebs because of the increased pressure because of water accumulations. There is membrane bleb formation. Okay, the most common organelle involved, as I already told you, it is the mitochondria, where sodium potassium ATPase pump is not functioning because there is hypoxia, and hypoxia means there is decreased phosphorylation, decreased ATP production. So for functioning of this sodium potassium ATPase, you need ATP na? What is the most important morphological features that you will see? This cell swelling or hydropic changes. Okay, and myelin figures, that are also important, but these are mostly not specific, but mostly seen in irreversible cell injuries. Okay, myelin figures are mostly seen in irreversible cell injury. Okay, so please remember that thing. Myelin figures are basically your phospholipid and calcium complex. Okay, that is there. So swelling of each and every organelle, mitochondria, Golgi bodies, and endoplasmic reticulum, and leading to membrane bleb formations. Okay, next, coming to irreversible cell injury. Okay, acha, apoptosis we will be discussing. In apoptosis, which kind of cell injury is basically functional there? Yes, it is the reversible cell injury, because I told you in reversible cell injury there is intact membrane, and in apoptosis also there is no inflammation because there is intact cell membrane. So this is important. The most common organelle affected in reversible cell injury is mitochondria. The organelle-wide calcification occurs first is mitochondria, and this mitochondria plays a pivotal role in apoptosis. Coming to very important one, that is irreversible cell injury. Now, irreversible cell injury, you have very important two questions from irreversible cell injury. First question, what is the most important changes? So basically I told you, whenever irreversible means there is mitochondrial dysfunction, and plasma membrane leakage. And this is irreversible, means you cannot reverse the condition. You cannot reverse the condition. The cell injury can be reversible, can be irreversible, okay, and or it can be free radical injury, or can be an endoplasmic reticular stress. Okay, so irreversible cell injury, it's a mitochondrial dysfunction and plasma membrane dysfunction. Okay, so because of the plasma membrane dysfunctions, the calciums will be entering inside the cells, and that will actually increase the cytosolic calcium, and that can increase various enzymes like your phospholipase, in your DNase, proteinase, your protease and ATPase, endonuclease, and that will break everything inside. Like there is DNA damage because of DNase, the proteins are getting damaged because of protease. Okay, the ATP production will be hampered because of ATPase enzymes, and phospholipase is the key player, because this phospholipase will break down the plasma membrane and will increase not only the plasma membrane, it will break down each and every organelle's membrane. Okay, the membranes will be broken down, and there will be amorphous densities. That's when these plasma membranes are broken down, the phospholipids will be free, that will combine with calcium and can cause flocculent amorphous deposits that are basically seen under electron microscope, and that is a very very important differentiating point between reversible and irreversible injury. That is the amorphous deposits or densities and in the mitochondria. Very important thing, nuclear changes that you see in irreversible cell injury. One is known as pycnosis, because there is pycnotic nuclei. Okay, that is clumping of the chromatin leading to hyperchromasia, that is shrinkage of the chromatin. Next, this chromatin will undergo fragmentation, that is what is karyorrhexis, that is fragmentation of the nucleus, and ultimately that will be dissolved. So there is dissolution of the nucleus, that is what is karyolysis. These are the changes you can see. This is the karyolysis, this is karyorrhexis, and this is hyperchromatic nuclei, that is pycnosis. Here you will be seeing breakage in the plasma membrane, as I told you, and you will be seeing large amorphous densities in the mitochondria, that will be seen under electron microscope, and plasma membrane defects. Okay, these are the myelin figures that are basically seen in both the cases of cell injuries. Okay, the next topic is our cell death, and many modes or mechanisms of cell deaths are there. We have necrosis, apoptosis, necroptosis, pyroptosis, ferroptosis, autophagy. Okay, just delivering few key points regarding each of them. Now, inflammation is present between these two, necrosis and apoptosis. Where inflammation is present? Yes, inflammation will be present in necrosis because plasma membrane is damaged. Okay, if you do gel electrophoresis, because the plasma membrane is damaged, so you'll be having the smear pattern of the DNA. Okay, there will be smear pattern. In apoptosis there will be step ladder pattern. Okay, what is necroptosis? There is necrosis plus apoptosis. Remember, it starts as apoptosis, but it ends with necrotic feature, means the morphological features will be typical of necrosis. The inflammation will be present, everything will be present, but it starts as apoptosis, so it's also programmed cell death. But we'll be understanding that in apoptosis there is a role of caspases. Okay, apoptosis have intrinsic pathway, extrinsic pathway, and in both the pathways you need initiator caspase and executive caspase. Okay, but this apoptosis that is happening in necroptosis, this is independent of caspase. Okay, that is dependent on RIP K1 and RIP K3. These are what present. Now, pyroptosis, as you can see, pyro means fever, so interleukin 1 will come into play, and obviously that is caspase dependent, and the caspase here involved is caspase 1. Okay, in apoptosis, two caspases are involved, two groups of caspase. One caspase is caspase 8, 9, 10. Another group is caspase 3, 6 and 7. This is what is known as initiator caspase. Okay, this is what is known as executor or executional caspase. Okay, among this initiator caspase, this 8 EIGHT 8 is for extrinsic pathway. So it actually initiates the extrinsic pathway of the apoptosis. And this 9 okay, is for intrinsic pathway of the apoptosis. It initiates the intrinsic pathway we'll be discussing. In ferroptosis, it is seen in iron overload state. So it is seen in iron overload state, and that increases the unchecked lipid peroxidation. And there is lipid peroxidation, and because of this lipid peroxidation, there will be increased features of inflammation. So peroxidation. Now please remember, in apoptosis, the marker of apoptosis is annexin 5 or annexin V. Annexin 5 basically. It's because of the phosphatidylserine flip. Okay, phosphatidylserine is present inside the cell membrane, and during apoptosis, this is represented outside. And once this is represented outside, now the macrophages will identify the annexin 5 and it will combine with the cell and can cause apoptosis. Okay, autophagy. The marker of autophagy is LC3. Autophagy means it's a survival mechanism where cell will damage or digests its own content. Okay, because of the stress or survival mechanism. So let us discuss one by one. Necrosis. So we have many kinds of necrosis here. First is coagulative necrosis. Please remember, it is seen in every solid organ except brain and pancreas. So except your brain and pancreas, it is seen in other solid organs. Here you will see colliculative or liquefactive necrosis. Okay, so it is seen except brain, yes, and this in fact very important. It has a, in necrosis, this coagulative necrosis has a typical margin also. Okay, keep inside this margin, the area is actually necrosed. It is considered as a type of dry gangrene, and the cell architecture is preserved. That is what I told. So the most common organ where you will be getting coagulative necrosis is heart. Okay, also you can remember Zenker's degeneration that happened in skeletal muscles. Okay, so this is what is important. Next is liquefactive necrosis. Now this liquefactive necrosis is because of the increased enzymatic activity that will cause liquefied material, and this liquefied material, this is considered as wet gangrene. The liquefactive necrosis is a wet gangrene where the cell structure are not preserved, and this is seen in brain. It can be seen in pancreas also, and very many kinds of fungal infections. Okay, caseous necrosis, very important. Caseous necrosis is seen with TB and histoplasmosis. TB and histoplasmosis, there will be cheese-like material that will be there. So cheese-like appearance is there, and this is basically combination of coagulative and liquefactive necrosis. Next we have fibrinoid necrosis, fat necrosis, and gangrenes. Gangrenes, I told you, dry and wet, coagulative and colliculative. So basically that is seen in arterial insufficiencies, like in ischemias, that is seen basically in the limbs. Fat necrosis is seen, the chalky white deposit in breast trauma. Please remember, trauma to breast, that will be given in the question. There will be chalky white deposits, and these chalky white deposits are because of the binding of calciums, that is called saponifications of the fat. Fibrinoid necrosis, that is seen in three most important conditions. One is your very important one is your malignant hypertension. This malignant hypertension may will be having concentric pink fibrin like material that are deposited in the arterial or vessel wall, that is seen in malignant hypertension. That is seen in vasculitis, that is polyarteritis nodosa, and also seen in rheumatic heart disease where the Asoph nodules are seen. Okay, this is basically type 2 and type 3 hypersensitivity reactions, and because of immune complex deposition that is happening. Okay, so you can see this is a coagulative necrosis, the liquefactive material. You can see this is cheese like material, so this is seen in TB, histoplasmosis, etc. This is coagulative necrosis that you can appreciate. Well defined margin is preserved here. Okay, this is artery and arterica. You can see this hyaline like depositions, that is fibrinoid necrosis. This is chalky white depositions, that is fat necrosis, and this is dry gangrene. You can see in the distal limbs and digits. Okay, next we'll be discussing the apoptosis. Apoptosis is a genetically programmed cell death, very important, and the most common organism where it is studied is a nematode, that is important. Now, the most common organelle affected is mitochondria. I already mentioned. Two pathways already mentioned: intrinsic pathway, extrinsic pathway. Okay, and I told you apoptosis happens in 3 phases. Okay, what are the 3 phases? You have initiation. Okay, you have execution of apoptosis, initiation of the apoptosis, then execution of apoptosis, and ultimately following the execution you will be having removal of the apoptotic bodies. So removal of the apoptotic bodies. Okay, so this is important. So pathways, 2 pathways, extrinsic and intrinsic, 2 phases, basically initiation phase and execution, followed by removal of the debris, removal of the apoptotic bodies. And very important enzyme, 2 enzymes are responsible. One is caspase, and I already told you what are the caspases are involved, and endonucleases. Okay, because endonuclease is there, it will fragment the DNA, and that's why you will be getting that step ladder pattern in apoptosis. Okay, and because karyolysis is seen in irreversible cell injury, that is why you will be seeing a smear pattern in necrosis. Understanding? And the markers I told you, annexin 5 or CD95 for the extrinsic pathway. Okay, so initiator caspase, okay, is 8, 9, 10. As I told you, 8 is for extrinsic pathway and 9 is for intrinsic pathway. Okay, and executional caspases all are required for extrinsic and intrinsic pathway both. Okay, now this apoptosis is regulated by 3 sets of genes. One is what is known as your pro-apoptotic factor. That means if these factors are there, they will increase apoptosis. And anti-apoptotic factor, if these factors are activated, that will not allow the apoptotic pathway to be activated. Okay, so the pro-apoptotic factors are buck, like bucks and buck, BAX and BAK. These are what is your pro-apoptotic factors. Okay, then you have anti-apoptotic factors like BCL2, BCL-XL and MCL. So you can remember this BCL, BCL and MCL. These are your anti-apoptotic factor. Okay, and next very important group is what is known as stress sensor. That is what is known as stress sensor. The stress sensors are the group which actually sense the stress, and accordingly it will activate the pro-apoptotic factor or it will inhibit the pro-apoptotic factor, and they are your BIM, BID, BAD, PUMA and NOXA. So these are the factors which will sense whether there is any stressful conditions or insults is happening, and accordingly if they are present, so they will all activate these pro-apoptotic factors. Once these pro-apoptotic factors are activated, then there will be apoptosis. Okay, and in this anti-apoptotic, they won't allow apoptosis. Okay, yes. So here is a statement, annexin A1 is the marker of hairy cell leukemia. The difference, very important. Yes, the difference is if that is an enzymatic procedure, then it's a necrosis. Now, yes, apoptosis, maybe there are enzymes like endonuclease, etc., there, but that is genetically programmed. It's not that every enzymes are haphazardly working like we have seen in necrosis. Okay, as it is programmed cell death, so it's an active process, obviously, and there is a single cell involved here. Okay, but here a group of cells, obviously, as necrosis is there, plasma membrane damage is happening, so it will involve the surrounding groups of cells also. And pathological necrosis is always and always pathological. Apoptosis may be physiological apoptosis, maybe pathological apoptosis. Physiological apoptosis ka example like in embryogenesis, okay, after embryogenesis, during organogenesis, okay, the remnants are uh, there will be apoptosis during embryogenesis, during involution of hormone dependent tissue upon hormone withdrawal, or even endometrial shedding is also an example of this physiological apoptosis. Okay, self-reactive lymphocytes, they will undergo apoptosis, or the during in acute inflammation neutrophil comes and serve its function, so after that neutrophil will be apoptosized. Whereas the pathological apoptosis, that is seen in case of DNA damage, that is seen in case of many conditions like misfolded protein diseases, that is seen in case of hepatitis B infections, diseases with count-Silman bodies, you will see pathological apoptosis. So cell size is decreased, cell size is increased. I told you hydropic generation, hydropic changes are happening in necrosis is also there, and that can lead to burst of the cell membrane will burst. And here the apoptosis means cell size is gradually decreasing. The cell membrane is intact and the inflammation is absent because the cell membrane is intact. Marker, I told you there is no specific marker for these things. Smear pattern and step ladder pattern, I told you. Okay. Next, few important other conditions, other associated in necropsis and apoptosis is necroptosis. I told you it's also programmed, but there is no caspase. Okay, RIP1 and RIP3, that is I told you this is mediated by this, not caspase. So no caspase. Okay, as the outcome is in necrosis, so inflammation will be present. Okay, then I told you it is seen in neurodegenerative conditions and mammalian growth plate formations. Pyroptosis, it is interleukin 1, and the patient will be having fever and infections. Okay, then coming to efferocytosis. Efferocytosis is basically whatever apoptotic bodies are formed, they will be phagocytosed. So the process of phagocytosis of the apoptotic cells. Okay. Ferroptosis, that is seen in iron overload states. When there is increased in iron, what happens? It activates the glutathione dependent defenses, and that increases the lipid peroxidation, and that will cause increased that will cause loss of membrane permeability and functions, and that ultimately will cause cell death. So it is because of the increased iron. Okay, so these are what you have to remember. Role of efferocytosis in cancer, stroke, and neurodegenerative conditions. You can remember this thing also. So basically efferocytosis is where the signaling process inhibits the pro-inflammatory cytokines. Efferocytosis is where the apoptotic cells are getting phagocytosed. Okay, what is entosis? Entosis, process in which non-macrophage cells eat and kill other cells. If it is by macrophage, it is efferocytosis or phagocytosis. But if that is happening by a non-macrophage, that is seen in case of autoimmune hepatitis, that is what is entosis. Okay, so this is what you have to be remembering. Now coming to ischemia reperfusion injury. Ischemia reperfusion injury is where the cell damage is happening following a reperfusion, means already the area was under hypoxic changes for a long time, but after that there is uh, ischemic changes had happened, and after that there is reperfusion to that ischemic area, and that causes free radical injury to that particular area. So you will be seeing that contraction bands of necrosis. Okay, that is what is ischemia induced reperfusion injuries. Next, coming to the calcifications, various kinds of calcifications we have dystrophic calcification, we have metastatic calcification. Very important, dystrophic is seen in dead tissues, so the cell is already dead. Calcification means either there is the calcification happening means deposition of excess amount of calcium. Now that can happen in a normal living tissue or can happen to a dead tissue also. That can happen in a hypercalcemic state, means the blood calcium level is already high, and in that background there is calcium deposition in the living tissue. That is what is metastatic. So you can remember it as calcium बढ़ गया तो ज़्यादा calcium means calcium, just you can remember it like that कि calcium ज़्यादा बढ़ गया means calcium will be metastasized to the other living tissues. So there it will be deposited and it will cause metastatic calcification. This is just a way of remembering. Okay, there is no metastasis of calcium. Here the serum calcium level is actually normal, but because the cells are dead, these calciums are deposited on that dead cells. Okay, so many examples are there for this calcifications. So dystrophic calcification ka you can remember as this mnemonic rheumatic vegetations, like it is seen in rheumatic vegetations, it is seen in atheromatous plaque, it is seen in TB lymph node. Okay, and this dystrophic calcification is also seen in necrosis, because necrosis में cell death हो रहा है, and it is followed by that, remember, amorphous deposits. So that is also kind of dystrophic calcification that is happening. Even a dead parasite is there in the biliary tract. Okay, so dead parasites, okay, that will be calcified, and that is because of dystrophic calcification. Obviously you don't have that increased calcium or hypercalcemia. You don't need hypercalcemia to deposit calcium in these conditions. Okay, two other conditions, one is that is known as what is known as Monkeberg, that is what is known as Monkeberg medial calcific sclerosis. Okay, Monkeberg medial calcific sclerosis. Okay, where you will also see the calcification in the tunica media of the blood vessels. Okay, that is different from your fibrinoid necrosis. Next is your Samoma bodies, where you will also see these are Samoma bodies. So you will be seeing basically these are dystrophic foci of dystrophic calcifications, and Samoma bodies are seen in many conditions like papillary thyroid carcinoma, papillary renal cell carcinoma, you'll be having serous cystadenocarcinoma of ovary, and you have prolactinoma, meningioma, many conditions are there. Okay, serous cystadenoma of pancreas also you'll be having these things. So the calcification starts in mitochondria, I told you, and the specific stain for calcium is von Caucha or Alzerin red S. Okay, so you can see the Samoma bodies. These are foci of dystrophic calcification, and that will appear densely basophilic and grouped as a foci. These are seen in this condition, I told you already. Coming to various pigment deposition disorder, the pigment deposition, we have many pigments like lipofuscin, hemosiderin, okay, melanin deposition. So many pigments are there. So this pigment deposition, the colored substances are getting deposited in various tissues, and that may be exogenous, may be endogenous. Exogenous means like you are the source of these pigments are from outside, so like by means of tattooing, okay, or by means of inhalation in occupational lung diseases, the carbon particles or those particles are getting deposited in the lung parenchyma, okay, from outside. So these are exogenous pigmentation. Endogenous, what we have to be remembering, these three are very very important: lipofuscin, hemosiderin, and melanin deposition. So please remember, the wear and tear pigment is, or aging pigment, that is deposited in the various organs with aging, is what is lipofuscin. This lipofuscin is this will appear like brown pigmentation, and that will be seen particularly in the perinuclear area, okay, and that represents a sign of free radical damage. So with aging, there is free radical damage or lipid peroxidation happening, and you will see this lipofuscin deposition. That is an age related condition. Hemosiderin deposition, that is because of iron overload, okay. You will see ferroptosis here also. Now, so iron overload condition like hemochromatosis or beta thalassemia major, because there is repeated blood transfusions, and that patients have a very high risk of getting this iron depositions in various tissues. That's why on repeated blood transfusion they are also they have, their treatment is also adjunct with your iron chelators. So here the patients, if you do histopathology, you will see golden yellow or brown color, golden yellow or brown color. But how to differentiate? Because see, I told you that lipofuscin also will appear brown color, it will also appear brown color. So the special stain for iron is Pearl's Prussian blue. So pearl stain or Prussian blue stain, that will give rise to a very very important stain for iron. Please remember, that will give a bluish color to the iron. So you can differentiate whether it's a lipofuscin or it's a hemosiderin. Also from the history, like hemochromatosis का presentation दिया होगा, or repeated blood transfusion of a thalassemia major patient is, then it's hemosiderin deposition. But if it's a aging process and you see a biopsy specimen of heart, or autopsy specimen of a heart is given, and there you see this deposition, lipofuscin deposition is given, that is what is this brown pigment is lipofuscin there, okay. Melanin is something where you will see that this is present in our body, and that is derived from tyrosine amino acid. Now melanin is present everywhere in our body, na? In brain, in the substantia nigra it is present. In brain it is present in the substantia nigra, okay, substantia nigra, and because of deficiency of that, there will be pale substantia nigra, Parkinson's disease is what you see. So that is a black colored pigment, and that is derived from tyrosine. What is the special stain that is used for melanin? Mason's Fontana, very important. That is a special stain that is used for tyrosine, that is used for melanin. There is another stain that is known by Masons also, that is what is Mason's trichome. Mason's trichome, okay. So this is, please remember, this is for collagen, it's not for melanin, okay, it's for collagen. Fontana is for melanin. Another important point of melanin, you'll be having a specific markers for melanin. What are the markers which are basically useful in melanoma? Okay, watch my video on melanoma, that is malignant melanomas, okay, in my playlist. See here, there I told you S100 and HMB45, these are the important markers which are raised in case of melanoma. S100, HMB 45, even melan A is, these are the markers which are increased. Okay, so this is important. Now please do remember, in hemochromatosis there may be bronze like pigmentation of the skin, but that is not because of your this hemosiderin getting deposited there, that is because of melanin. Okay, so this is what we have to be knowing. Next we are discussing cell aging, that is the last topic, cell aging and the important aspects of the telomeres. So there is a telomere-telomerase hypothesis, and the telomere is basically a sequence of nucleotides that are getting repeated at the end of chromosomes, and the sequence is your TTAGGG. These are the short repetitive sequence of nucleotides at the end of chromosomes, and the sequence is this one, and this sequence is getting repeated many times, but this is not going to be replicated, that is not going to be replicated in the successive cell division. So in each and every cell divisions, this particular end is actually cut from the chromosomal length. So every time the chromosome is getting shorter and shorter, and this is getting shorter every time in each and successive cell division, and that is leading to a loss of cell division potential of a particular cell, and that is where your Hayflick's limit is. Hayflick's limit for a normal cell is around 60 to 70. That means a cell can divide 60 to 70 times in a lifetime, but uh, after that the cell will age. But telomerase is something which synthesizes telomere. Okay, so if telomere is synthesized, the cut portion that could not be replicated, that can be regenerated now. Okay, so that will inhibit cell aging. These telomerase are normally not present in our somatic cells, but these are present in our germ cells. High telomerase activity is seen in germ cells, stem cells, because that's why that is known as immortality gene. And you have this telomerase which is absent in somatic cells. This telomerase is very very important component of cancer cells, because they have no Hayflick limits. Okay, they have no Hayflick limits. The cancer cells are usually have high telomerase activity, that's why they can divide for lifetime. Okay, they can divide for lifetime. So this is what is Hayflick's limit. I told you normally cells undergo 60 to 70 cell divisions in their lifespan. Warner syndrome, okay, and that is premature aging due to defect in DNA helicase. Please remember, it's not Warner syndrome. What is Warner syndrome? What is Warner syndrome? Warner syndrome क्या है? Warner is basically another name of main one no, main one syndrome. What is the chromosome? Main one gene is present in which chromosome? Main 1 is present in 1, that is 11. Main 2 is 10. Main 4 is 12. Okay, so this is Warner syndrome because of defect in the DNA helicase. So DNA helicase helps in DNA unwinding and repair. Because of that defect here, it cannot even unwind the DNA or repair the DNA. So there is premature aging happening. Okay, very important thing here you have to be remembering is what is known as sirtuins. This is needed for longevity basically. Okay, so how you can increase sirtuins? So the sirtuins can be increased by decreasing or restricting the calorie intake. So जितना कम खाओगे उतना ज़्यादा अब जी पाओगे. So that is what is on calorie restrictions increase lifespan. And wine consumption can also increase the longevity, but that should be up to particular level, up to particular limit. Okay, so this plays an important role in diabetes, cancer and cell aging. Okay, that is a very new concept here, that is NAD dependent protein deacetylases. These sirtuins are nothing but this reduces the free radical injury and increases the insulin sensitivity and increasing the DNA repair, by which it can protect us from this dangerous conditions. But the questions asked, this calorie restriction can increase the sirtuins level. Okay, so this is what we have to be remembering. We will be ending up this session with various kinds of stains. So we have the most common stain is our hematoxylin and eosin, that is H and E staining. Okay, but what is the most common stain used in hematology? It is the Romanowsky stains like Listman stain, Zimsa stain, etc. Okay, if they ask you what is reticulocyte stain, very important, it is supravital stain. It is supravital stain. Okay, supravital stain. What is the stain used for lipid? Yes, Sudan black or oil red O. Sudan black or oil red O. What is the stain for iron? Iron का stain क्या है? Yes, that is Prussian blue. Iron stain is Prussian blue. Calcium stain I told you, that is von Caucha or Algerine red S. Okay. What is the stain used for copper? Copper is rhodamine and rubinic acid. Rhodamine or rubinic acid. Okay. Mucin I told you in Barrett's, it is mucicarmine or Alcian blue. Mucicarmine and Alcian blue. Okay, these two I told you. Collagen is Mason's trichrome, so C for collagen, and melanin you have Fontana, Mason's Fontana. This was micro questions. H. pylori, Wartine star is silver, black H. pylori you will see. Okay, and also amyloid, I told you in amyloid, one of my TFS series videos you can watch. The specific stain for amyloid is Congo red. Congo red will give salmon pink appearance. Salmon pink appearance on light microscope, na? On polarized microscope, on light microscope. Under polarized microscopy you will see that apple green birefringence. That is because of the cross beta pitted sheet structure. Okay, what is the stain used for cryptococcus? India ink. Okay, India ink. Gomorymethanamine, PAS, that can also be used in fungi, but PAS can be used for glycogen also. Okay, this here. The question asked is about mast cell also, that is toluidine blue. Mast cell important in type 1 hypersensitivity. Type 1 hypersensitivity reaction, IgE increased, atopy, bronchial asthma, anaphylaxis. Okay, these are there. Okay, what is the stain that is used for reticulin fibers? For reticulin fibers you can remember, for reticulin fibers what is the stain used? Yes, it is silver. Silver used for reticulin fibers. Okay, what are the stains that are used for lymphoblast and myeloblast? Lymphoblast and myeloblast. For lymphoblast it is periodic acid Schiff. For myeloblast it is NSE, that is non-specific esterase. NSE or SBB, Sudan black can also be used, but NSE you can remember. So this is all about revision of general pathology. We'll be coming with another revision sessions. Thank you.